This is Roger Green, host of the Surfing the MASH Tsunami podcast. This week, we are offering 5 conversations from episode 23, our discussion on challenges in physician-patient communication stemming from a session at the EASL Congress, with Louise Campbell, session co-chair Shira Zelber-Sagi and Mike Betel, and panelists José, Willemse, and Tom Marjot. Plus, from the vault, a discussion from Shira's previous appearance on Surfing MASH in the U.S. Thanksgiving 2022 special. This episode's a bit unusual for 2 reasons. First, I'm not part of the conversation. Louise leads it brilliantly in my absence. Second, it focuses far more on the patient and the role of the physician-patient interaction in steering treatment. I found this fascinating and hope you do as well. This final conversation focuses on shared experience and holistic MASLD support programs. It starts with Tom suggesting that shared experience is a pivotal factor in patient support groups and patient-based supportive care. He refers to examples in viral hepatitis, where many of the patients had common background challenges related to the disease. In viral hepatitis, the patients who are treated successfully can become integrated into the care community itself. Nothing like that happens in MASLD at this time. Louise comments that this would be particularly useful due to stigma around the disease, stigma that successfully treated patients have overcome. Louise also points out that Michael makes extensive use of shared experience videos, such as this month when he has invited patients to follow him on what he describes as his 30-day glucose challenge. Michael says he gets unsolicited notes about how helpful the approach is, along with diet recipes. He also agrees with Tom that a viral hepatitis model might provide help here. Continuing, Mike discusses the idea of metabolic disease support programs that take a more holistic approach and place MASLD in a broader multi-disease context. Shira likes the holistic approach as well, including with the focus on mental health. Tom agrees with the basic approach, commenting that the multitude of possible issues and how they confound each other is what makes MASLD treatment so tricky. As the conversation wraps up, 2 final themes emerge. 1, physicians must be actively curious in exploring each patient's needs if therapy is to optimize. And 2, joint goal setting is an excellent strategy to drive incremental changes in patient behavior. As I noted at the beginning of this introduction, this episode has a few things that make it really different. Focus on patients, me not being a part of it, and a really engaged panel that has diverse backgrounds. Conversation moves fast, covers a broad range of issues, so just sit back, listen, learn, absorb, and when you're done, join the conversation in our LinkedIn discussion group.
Tom Marjot.
The lived experience side of things, where I've seen this best, is within the viral hepatitis space, which is people that have had really tough lives, who have overcome lots of barriers, who have got treatment for their hepatitis C, and then are now becoming integrated within the care pathway for outreach and to target patients and to help recruit patients into eradication. And so they're really using patients with lived experience to actually become part of care delivery. And that's really powerful within the viral hepatitis space. But I don't think we've seen that yet within the MASLD space. For example, patients that have had loads of metabolic risk factors, have done really well to lose weight, have overcome lots of challenges, have seen their liver disease get much better, have adopted their healthy lifestyle. I'm not seeing those patients yet be integrated back into the healthcare service as a motivation and inspiration for other patients in the clinic. And I think the viral hepatitis model is so powerful and so persuasive that we should probably be taking really, role model patients and making them more visible for our MASLD patient.
Louise Campbell.
That's important because we can start at a level of higher start because of that lived experience of viral hepatitis. And you're right, and it was something that was in the room along with the questions of stigma. And I think Donna Cryer got up and talked about the fact of motivational patients who've been there, done that, got the t-shirt. So not just focusing on that, but that whole look at somebody who's done it, that exactly what you've described there.
I remember that conversation in the room, a patient herself saying we should be wheeling out patients that are really strong role models with big presence either on social media or good speakers. And, again, it plays into the ability to motivate. And actually, that was kind of a new thing in my mind about it's not just involving patients in workshops and side rooms to inform grants and to inform, policy. It's actually being much more vocal, at having a role in care by motivating their peers.
Michael, you're obviously strongly involved with GLI and that whole motivational, and a lot of your videos are highly motivational, as well as fun and informative and education. And how much feedback do you get from your patient community on how that motivates them to take the next step? You're saying some of the comments on the work that you're doing at the moment being 24/7 monitored.
Mike Betel.
I'm getting actually a lot of people writing and saying that it helps them with some of their food choices that they're making more than you think. A lot of people are just sending me comments. Sometimes I'm getting suggestions of what to eat, and I'm throwing those in when I can without killing myself when I know it's not the right thing to choose. But I agree with what Tom said about the Hep C model, because I was very involved at the very beginning after non-A, non-B when Hep C first started, monotherapy, and patient support groups were quite important when in a focused area. I don't think in Canada for sure they're not at a MASLD isolated support group. I've been doing I've done 2 and I'm planning to do more across the country, metabolic community education sessions where I bring in a hepatologist and a nurse clinician and a patient and talk about how type 2 diabetes, obesity, and liver disease are all so closely related, and that you can help to work on one and you're working on all of them. And so I think in the short term, that metabolic approach, I know Shira believes in that as well, for sure. That might be a better way to bring in some of the people in some of those other circles in the Venn diagram of metabolic comorbidities.
Shira Zelber-Sagi.
I also believe in holistic approach. So we don't treat an organ, we treat a person. So we treat liver disease, but all other diseases, we treat mental health. We need to be sensitive to socioeconomic status and so on and on. I mean, a holistic approach, I think this is the approach we should use nowadays.
And that's why MASH is tricky for lots of reasons, both clinically, but also from addressing patient needs, is because it is so multi-systemic with so many moving parts, being managed often by a liver doctor, which is only one tiny portion of the pathogenesis of the condition. So I actually think MASH patients have it tough for lots of reasons, but because there's so much to tackle, they're at high chance of having their needs unmet. So I completely agree with you. The more holistic and the more multidisciplinary approach to these patients, the more chance we have of really making a difference to quality of life.
Yeah. And interestingly enough, that brings us full circle to that full interaction with the patient at the beginning and knowing about them, finding more about them, because you're the most powerful person in their life, apart from their partners and their family, for the next 20, 30 years, going back to what José is saying. So those extra few minutes, really digging down and finding out more about your patient, gives you that better base for the holistic approach. So that's a nice place to sum up, because we are at the top of the hour here and it's been a great discussion. But I'm going to ask each of you, if you had to take one part away from the discussion today and for the challenges that patients face, what would be your one tip to the physicians listening, and where to take their patient care and how to help break down those barriers that are currently faced? Brave one, go first.
My take-home message really is that you shouldn't just assume that addressing the patient's needs is going to be automatic as part of your consultation. You have to really be focused on integrating that within your consultation. And so turning off the computer screen, giving dedicated face-to-face time and space, and allowing that space in your consultation to allow the patient to, voice their concerns is paramount. You can't just assume that's going to happen. You need to consciously build that into your clinic model. Do you agree, José?
I agree with you completely. I would add to that partnership. We should have shared goals, shared decisions about how to do the treatment, how to move on, set realistic goals together. It's a partnership. That's what it is.
I would say it would be great if physicians could actually and honestly be curious about the needs of that particular patient in front of them, and to ask because they actually really want to know, not just because it's the next patient and they're trying to get through the patient stream.
José Willemse.
Well, this is not surprisingly probably, because I come back to my mantra. Just do it once a year. Ask how it affects people's life. And because then you will get a lot of information as doctor, and the patient will be happy that you asked that.
Wonderful discussion. Thank you. I'm going to jump on something that Shira said in that as one of my take-homes now, I suppose, is this setting goals. Healthcare is very good at setting goals, measurable. So we do that whole model all of the time. The patient doesn't only have to be the person writing the goals. The joint goal setting is, what are you going to do for me, doctor, and I'm going to do as well. So there can be, and I think that was a beautiful thing that you said there, we can set dual goals of what we're going to achieve together and have that reviewed with the question of, how did that affect your liver, affect you this time? How did we achieve our goals that we've set together? And we walk together hand in hand as a partnership. And I think if that helps break down those barriers, then it was a fantastic session that was done. There were lots of things suggested. I've listened with avid intent to the discussion going on, didn't feel any need to interrupt because it flowed and you answered the questions that were posed. And I think that's the natural place to go. The answers sometimes can be very simple, but we do need to, as you've described today, sometimes think out of the box. And I love stretching healthcare beyond those boxes. So thank you all for joining me. And it was a wonderful session. And for anybody who has access to the EASL platform, you can review the entire session and watch it and have a look at the other speakers who were amazing as well, discussing the stigma, what's happening in cancer, viral hepatitis, and things like that. And also, if you wanted to attend another session on the diet, Michael and Shira are the dream team because they did the sellout session for the diet, which led into the new practice guidelines, which of course, Shira, you are part of the development of them. So the dream team, presenters and co-hosts for EASL.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any comments or questions about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded the conversation, or send an email to questions@surfingmash.com. It's not clear what we're going to be doing next week. We're looking at approaches featuring NITs and a separate one focusing some basic science. Either way, I'm sure it'll be fascinating, and I can't wait for us to put it out for you next week. Until then, stay safe, surf on. We'll see you on podcast. Bye-bye now.